So FLT3 inhibition is a very hot topic. We have a lot of drugs. We have midostaurin in the frontline setting. We have gilteritinib in the relapsed refractory setting. So I think the main question is here is the optimal sequencing. Should we use novel class 2 type FLT3 inhibitors such as gilteritinib or quizartinib upfront, or perhaps using less selective inhibitors such as midostaurin in the frontline setting and leaving the selective class 2 inhibitors, second generation inhibitors in the relapsed refractory setting? So I think this is an important debatable topic, how to optimally sequence them. Another part is actually the resistance mechanism, both to older first generation FLT3 inhibitors and second generation FLT3 inhibitors. The resistance mechanisms seem to be different. That is also an important part of how to optimally inhibit the FLT3 with the current drugs we have available. Of course, an important part is of course the post-transplantation maintenance. What is the optimal FLT3 inhibitor for the post-transplant setting? We have good data with sorafenib. Really looking forward to the detailed evaluation of the Morpho trial. But I think in the future we also need to address the hot topic of the FLT3 inhibitor use in the unfit population setting, whether we should proceed with the triplet therapy, adding FLT3 inhibitors to aza-ven, or leaving it as a sequence after the relapse post-aza-ven, and then using FLT3 inhibitors as a salvage therapy. So I'm really looking forward to the clinical trials, which will hopefully address these questions and we'll have a better understanding.